The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Patrick Keenan. I'm the Policy Director for the Pennsylvania Health Access Network. Thank you so much for joining us today. We are excited to have all of you on what is a really important webinar topic. As you can see on your screen, this webinar is entitled Block Grants and Per Capita Caps: What You Need to Know About Potential Cuts to Medicaid. We appreciate all of you joining. We know that this topic has a particular sense of urgency because of conversations that are going on right now in Washington. We are excited to have with us Kristen Dama from Community Legal Services, who has been a friend to many of us in the healthcare advocacy and policy community, because she's been guiding us through really complicated issues for quite a bit of time, starting with our fight for Medicaid expansion, and now on to the fight to protect Medicaid from what could be some serious threats. So without further ado, I'm going to turn it over to Kristen with just two quick housekeeping announcements. You should have a chat window and an opportunity to ask questions. Please feel free to do so throughout the webinar. If you're having any kind of trouble whatsoever with audio or anything else, we'll try to help you out. And we've allowed in this hour and a half time plenty of time for questions. So we may take a couple of breaks to answer some of those, but we'll definitely save lots of questions for the end. So without further ado, I'm going to turn it over to Kristen Dama from Community Legal Services. Kristen?
Hi, everybody. Thank you all so much for joining this call and giving CLS, Community Legal Services, and FAN an opportunity to fill you in on what's happening. I know from looking at the list that there's lots and lots of Medicaid experts on this call. So I'm going to give a little warning that the first part of the webinar, we're going to run through some background about how Medicaid works and how Medicaid is funded today. I think it's important that we all are on the same page before we start thinking about what changes might occur. The second warning I want to give is that we don't have a firm block grant proposal or a firm per capita cap proposal that we can really parse for you today. What we're going to be talking about are some of the general themes that we're seeing emerging out of Congress, and think tanks that support these plans, and what we might expect is coming down the road. But as soon as a proposal is available and we've had a chance to analyze it, our plan is to partner again with FAN to regroup and come back together and talk about what we know down the road. But for now, this is a general background about how per capita caps and block grants work, how they might diverge from the existing Medicaid world, and what we can expect and what we should be doing in the next few months as more of this conversation happens. One more housekeeping piece before we start. This is a call that is geared toward advocates and people who are interested in these issues. It's not geared for press. If you are press, you're welcome to stay, but this is presented as background and is not intended to be an on-the-record conversation. If you'd like to speak on the record, you can certainly contact me after the fact. And with all of that said, just a little bit of background. As Patrick says, I've been doing Medicaid work with FAN and with other partners for the last 10 years. I work at Community Legal Services, and we are the largest civil legal services program in the state. Low-income consumers a year on a range of issues related to employment, criminal record expungement, landlord-tenant issues, including eviction defense, mortgage foreclosure defense, other consumer issues, and public benefit denial, range of public benefits, including Medicaid, which is, as I said, where my practice lies. There's a lot of systemic advocacy across the state, focusing on class action litigation, policy at both the state, federal, and local levels, and our focus is really on in the public benefits world where I live, on really preserving and strengthening the safety net for people who are really struggling to get by, and so we are really feeling like Medicaid is under attack, while we wear those hats. and that it's really up to us, not meaning just CLS, but all of CLS and all of our partners across the state, many of you, to really do what we can to preserve the safety net for the people who need it most. So with that said, let's talk a little bit about Medicaid. This will be a review for lots of folks. Traditional Medicaid, the Medicaid program that existed before 2014, before the Affordable Care Act took full effect, was a program that did not cover every low-income person. It covered only people that Congress had viewed to need extra help. And what that meant was that it covered seniors, people over 65, in some cases maybe people a little bit younger, but older adults, individuals with long-term disabilities, so individuals getting Social Security benefits, supplemental security income benefits because they've been found to be disabled, or individuals that states had determined had long-term disabilities that maybe hadn't been found disabled yet, but had these 12-month disabilities. Children, depending on the age, under 19, under 21, depending on the state, pregnant women, and very low-income parents, so parents who were income eligible for the TANF cash assistance program. This world, even though the Affordable Care Act took effect, and we can talk about what that means in just a moment, this world still exists. We still, behind the scenes, have these this existing regime of traditional Medicaid. And when somebody walks into the county assistance office, they don't say necessarily, I'm here to apply for traditional Medicaid. They're just there to apply for health coverage. But behind the scenes, the computers still recognize these pockets of eligibility. And they're not just one or not just the five that are listed. There's actually about 30 different programs that knit together to make the traditional Medicaid infrastructure that has existed, since the 1960s and still exists today. But as I said, the consumer interface doesn't really interact with this. But it still exists, and that's important for a couple reasons, which we'll talk about in a second. Every state has traditional Medicaid. This is a world that this is a nationally adopted program. That doesn't mean that every state's program looks the same. As we'll talk about in a minute, every state has different flexibility, but every state has traditional. All 50 states plus Washington D.C. have traditional Medicaid in effect. Medicaid funding is complicated, like all things related to Medicaid, but in general, the federal government pays about half, and in some cases a little bit more, and states pay for the rest of traditional Medicaid. And so it varies. It varies depending on how wealthy the state is, and what I mean by that is how robust the state economy is. The average federal share of Medicaid is 57%. But there's fluctuations. Some states pay 50% if their economies are relatively robust, and some states pay much less. So you can see, Pennsylvania gets 51%, almost 52% of its costs paid. And that's been, it was about 55% during the recession. Now that our economy has gotten stronger relative to other states, we've kind of hovered around this 51, 52% limit for the last couple years. New York, New Jersey, Connecticut, actually Alaska, that has a lot of oil money in their economy, they are all at 50%, which is sort of the minimum that states get. But then you can see states that have less robust economies get reimbursed at much higher rates. Mississippi, Alabama, Arkansas, Kentucky, West Virginia, those are states that get 70% and up is paid by the federal government, and the state share is much lower, is more around between 25 and 30% of their share. And the way this happens is that every quarter, states, Pennsylvania, other states report their costs to the Federal Centers for Medicare and Medicaid Services, and they get reimbursed for the previous quarter's expenses. So on a quarterly basis, states are being reimbursed for their share of the federal share of their costs. We have this new world that many of us are familiar with, expanded Medicaid, which under the Affordable Care Act required that anybody who wasn't covered by traditional Medicaid up to 138% of the federal poverty line could be covered by Medicaid. And as many of us will recall, in 2012, the U.S. Supreme Court ruled on the constitutionality of the Affordable Care Act, and one of the holdings was that Medicaid expansion could not be required of states. States could have So you have a lot of discrepancies among states beyond the differences in how states have implemented traditional states that have and have not expanded Medicaid, and the coverage really varies depending on state lines, depending on where you are and especially what region you are in. Medicaid expansion is funded much more robustly by the federal government. It was funded for the first 3 years at 100% by the federal government. That share is declining slowly to 90%. So for this year, states are being reimbursed for 95% of their costs. That'll decline just a little bit for the next couple years, and then it will stay steady at 90% federal funding, assuming that everything in the healthcare world looks the same in 2020, which is a hard thing to assume at this moment. But this is what the Affordable Care Act contemplates. And so when I was saying a minute ago that traditional Medicaid still exists, this is why. This is the stuff that's happening behind the scenes that the consumer shouldn't see. When they walk into a county assistance office, they're supposed to apply for Medicaid, and they're supposed to be slotted either into a traditional Medicaid category or in a Medicaid expansion based on their circumstances. And the reason this matters is because it depends on how much money that person how much reimbursement that person then qualifies for from the federal government. So if you're a kid and you walk into the county assistance office and you say, you're a parent, I guess, applying for your kid, you say, I'm applying for my 14-year-old, that person is going to be attributed to the traditional Medicaid program, and they will be, Pennsylvania will draw down a 52% match for that person. If that person walks in and they are a healthy 26-year-old, 27-year-old with no disabilities, they're not pregnant, then they'll be assigned to the Medicaid expansion category and we'll draw down 95% for them. So this is a really tricky world that we are living in. There's lots of people at the state level and at the federal level who are making sure that the math is done correctly. There are audits. There's all kinds of adjustments and safeguards to make sure that states are assigning people into the right pocket and that the federal government isn't overpaying as people are assigned to these different categories. Again, very, very complicated, but this is the world we have. It's not seamless, but it makes sure that states get reimbursed appropriately and fully for the cost of their Medicaid programs. Pennsylvania, as many of you will recall, expanded Medicaid in 2015. We were a year late, so we did miss that federal match for 1 year. But since then, we have expanded Medicaid, and we have a very robust Medicaid program. We have 2.2 million Pennsylvanians who are covered and who receive traditional Medicaid. We have, of that, we have 1.2 million Pennsylvanians that are covered in the traditional Medicaid program are children. A huge number of our Medicaid program are children. And I think people often think, CHIP is the program for kids. But in fact, CHIP is an add-on for kids who don't qualify for Medicaid, but the vast majority of kids across Pennsylvania are covered by Medicaid. And then we have another 700,000 Pennsylvanians who are newly covered by Medicaid expansion. So when we talk about Medicaid, we're really talking about a program that covers 3 million Pennsylvanians, or very close to that amount. The last public data that's available is from fiscal year 2015, which runs from October 1st, 2014 through September 30th, 2015. And for that period, our Medicaid program cost about $23 billion. This is not a cheap program because, again, we're covering 3 million people. For fiscal year 2015, $13 billion, so about 55%, was reimbursed by the federal government. The Pennsylvania share was about $10 billion. This doesn't perfectly capture what's happening in 2017, and the reason is we didn't expand Medicaid until 3 months into the fiscal year. So this data doesn't capture what a full year of that 100% match looked like for Pennsylvania. And so the federal share is probably quite a bit more now, but I do not have more up-to-date data for you. It's important to note that the most people who are getting Medicaid in Pennsylvania are children or people people who are healthy, people who are getting Medicaid expansion because they are lower income, they need some help making ends meet, but they are, in many cases are working, are going to school, are really working on stabilizing their lives. And so that's about 2 million, a little more than 2 million of the people on Medicaid in Pennsylvania. But the vast majority of our spending, I was looking at some data trying to get you all a real number, and the last number I saw was from 2011, said 75% of our spending goes toward individuals with disabilities and seniors, older adults, many of whom need home and community-based services, much more expensive services. The Urban Institute has some projections for 2017. They say we spend about $1,000 a kid and about $13,000 for somebody with disabilities. So you can see, how you have a program that is spending is really skewed toward people who have much higher medical needs. We are actually covering kids and people who don't have a lot of medical needs very cheaply, very efficiently. Medicaid in general is an efficient program that where dollars are spent pretty wisely. States have some requirements that they have to follow in their Medicaid program right now. I think the most important one is that Medicaid is an entitlement. So anybody who qualifies has to be enrolled. And that means that if you walk into a county system office and they don't want to cover you, they can't turn you away or put you on a waiting list and say, I'm sorry, we've reached our maximum number of people who can be in a program. And that's really important because that's not the way block grants work. There are waiting lists for waivers, which we'll talk about in a moment, waiver programs. We'll talk about what those are and how those work in a sec. But in general, anybody who applies for Medicaid and qualifies has to be enrolled. There are some other rules that strengthen the Medicaid program and make sure that it's administered fairly. Eligibility decisions have to be made promptly without excessive paperwork. You have to use electronic data, so if you can determine someone's citizenship or someone's immigration status electronically using government data sources, that's the approach that the states are required to take. This is both to simplify administration and also to make sure that programs are being, the proper people are being enrolled in the proper benefits. There are certain benefits that have to be covered, and this is a little bit tricky to generalize about because there are different requirements for what have to be covered by traditional Medicaid versus expanded Medicaid. Expanded Medicaid tracks, in many respects, benefits that are sold in the marketplace, whereas traditional Medicaid has a different set of requirements. But there are benefits that states can choose to cover and get a federal match for, and then benefits that states have to cover, especially hospitalizations, certain doctor's visits, kind of that baseline medical care. Some of the other provisions are intended to really focus on ensuring access and also making sure that the particular needs of lower income people are met. And so enrollees have to have access to federally qualified health centers, and they have to have a choice of family planning provider. These are two things that we saw the federal government was very adamant about when we were talking about the Healthy Pennsylvania waiver plan, which would have changed how Pennsylvania expanded Medicaid in a way that wasn't entirely compliant with these requirements. But this is something that traditionally the federal government has held firm on requiring states to do. And finally, states can't discriminate. The federal government has a number of anti-discrimination provisions to make sure that benefits are provided in a way that is compliant with the Americans for Disabilities Act, the Civil Rights Act of 1964. There's no age discrimination. There's a lot of protections in place to make sure that Medicaid programs are administered in a way that respects the rights of all applicants and recipients. With that said, states have lots of flexibility in how they design their Medicaid programs. They have the ability to cover optional benefits and get a federal match for them, and that includes things like optometry and dental care. They can decide to provide coverage directly from the state, and bills go directly to the state on what's called a fee-for-service basis. So you go to the doctor, the bill goes straight, and the bill goes straight to the state Medicaid program, and the state Medicaid program pays it. Or they can use managed care and enroll people in healthcare companies like Aetna, Independence Blue Cross, and a number of UPMC, a number of programs across the state have traditionally or are continuing to provide managed care. And they can implement limited cost sharing. There are rules around how much people can be required to pay out of pocket, but states can decide to implement those rules and decide to charge people when they go to the doctor up to a certain amount, to have out-of-pocket maximums, those kinds of things to make sure that, depending on the state's view, some states feel strongly that they want people to quote-unquote have skin in the game, which is, not always what advocates are looking for, but this is an option that's available for states. States, beyond the sort of this general flexibility, states can file and affirmatively seek waivers of federal Medicaid rules to test out new ways to provide care. So they can decide, we understand these rules, we think we want to do things a little bit different. We're asking you, the federal government, to waive Medicaid requirements so we can try to do things a different way. And what the federal government has generally said is that we will grant waivers, but they have to be related to the purpose of the Medicaid program. And the purpose of the Medicaid program is in the first part of the Medicaid Act, and it says it's to furnish medical assistance. And so what CMS, the federal Medicaid agency, has been really good about is saying, there are some things that allow states to furnish medical assistance better, and there are some things that don't have anything to do with furnishing medical assistance. And so we saw this with Healthy Pennsylvania, when Pennsylvania wanted to impose a mandatory work requirement for people, or they wanted to lock people out, they wanted to put premiums into place and to lock people out of coverage for 3 months if they didn't pay their premiums or they couldn't pay their premiums. And what CMS has said in those cases is, no, we're not going to allow this because, locking people out of coverage or requiring people with hardships to go to work is not related to furnishing medical assistance. That's related to other state goals that are too attenuated. Pennsylvania has taken advantage of plenty of this flexibility. We have a robust benefits package, and we get federally reimbursed for 52% to 95%, depending on who gets it. We cover some dental care, not an overwhelming amount of dental care, but basic dental benefits. We cover optometry, not really eyeglasses, but eye exams. We have services that we cover, that we have opted to cover because people in the Department of Human Services have made a decision that covering these benefits, that it is, that not covering these benefits is penny wise and pound foolish. Like, it makes sense to put the money into preventive care, keeping people healthy in all aspects of their lives so that they don't develop health problems down the road. We are a managed care state. People are required to enroll in the Health Choices Managed Care Network. That means that states pay fixed costs for people, and if people have very expensive services down the road, then the managed care networks have to bear those costs rather than the state. We charge nominal copays for doctor's visits, prescription drugs, and hospitalizations, and we have made eligibility rules more flexible to cover certain populations, and one of those is the Families of One program, the PH95 program, which covers children who may have slightly higher incomes than they would otherwise have through Medicaid, children with autism, other serious disabilities, so that they can get supportive services at home, in their communities, or in schools that maybe maybe other insurance companies might not pay for, other sources of insurance might not pay for. We also have 11 federal Medicaid waivers that allows Pennsylvania to, most of them allow Pennsylvania to provide home and community-based services to seniors and individuals who have serious disabilities so that they can age in place in their homes rather than having to be moved into nursing homes, which is more costly and often not desired by the people who are seeking these services. So why don't we just pause for just a sec on this general Medicaid world, sorry I'm having, and see if anybody has any questions, and then we can start talking about block grants. Patrick, I'll turn it over to you.
So if anyone has any questions, if you want to ask them using your computer's audio or the phone audio, you can feel free to raise your hand and I would be happy to unmute you. You can also, there should be a place where you can type questions into a box and I can put them to Kristen. So again, there's two options for raising, and let's see. Miguel Torres, I'm going to try to unmute you at the moment. Miguel, are you there? Do you have a question for Kristen?
Hey, how you doing? I just have a quick question, and we had a meeting earlier today, but I just wanted to make sure I have the correct. Now, Medicaid, is it going to be expanded county-wise, or is it just in Philadelphia, or is it the state in total?
So Medicaid, so the Medicaid regime that I just talked about that has both expanded Medicaid and traditional Medicaid, that is a statewide program. So in Philadelphia, where I know you're located, you can certainly, people can access, you know, almost any person, lower income person can access Medicaid. That is also true statewide.
Great, thanks Miguel. Did that answer your question? All right, our next.
All right, anybody else? Patrick, or should I move on?
Monica, are you there?
Hi, thanks a lot. This is Monica. I'm in Philadelphia at Project Home. I was wondering if you had just general stats. Thanks for the stats on the number of people in Pennsylvania that are on Medicaid, but do you have any general stats on people who are dual eligible? So of those 2.2 million that are covered, or 3 million people that are covered under Medicaid, traditional or expansion, do you have any idea about the percentage that are dual?
I don't know off the top of my head, but I know those stats exist. If you want to follow up with me after this call, I'm happy to try to connect you to those.
Cool, thanks a lot.
My information will be at the end of I'll have an email address at the end of this.
Yeah, the reason I ask is only just, I think if we have a sense of like the scope of older people and seniors that are affected, people on Medicare, that might change kind of how we think about our advocacy strategy, especially if it's like a large, you know, number of older Medicare recipients.
Yeah, sure.
Yeah, just a thought.
Those numbers absolutely exist, and I will connect you to them after this call. And for folks who are looking for that kind of general information, I find, you know, there's state data that is publicly available through DHS website, and there's also the Kaiser Family Foundation has a state health facts website, statehealthfacts.org, that allows you to look at each state. Some of the data is from 2015, some of it's a little bit older, but it allows you to play around with demographics and really understand who's getting Medicaid.
Kristen, we have another question from Liz Healy. The question is, does the total spending for Pennsylvania Medicaid include spending on home and community-based waiver services?
Yes, I believe that number does. And the idea is that that number is lower than it otherwise would be because it's cheaper to provide people in home and services for people in home and community-based services than it is to provide them in nursing, for them to provide care in nursing homes. But even so, you know, when I start talking about this number, you know, $13,000 to cover someone with disabilities versus, you know, $1,000, what that really reflects is not just the cost of providing the basic medical care, but also in some cases you know, that average also includes home and community-based services.
Okay, and I think the last question that I see here, again, if you have a question, you can either type it into the window or you can raise your hand. Either function will allow you to get a question to us. But the last question I have right here is, of the 700,000 people on Medicaid expansion, do we have a sense of how many are living in rural Pennsylvania? That comes from Terry Hoffman.
Yeah, that's a great question. We do have county by county data, that is something that I can definitely provide to folks who are interested, or Patrick can as well. I know Patrick has it in hand as well. Medicaid expansion does not exclusively help Philadelphia. I mean, Philadelphia has its number of enrollees because Philadelphia is huge, and it is a city with a pretty significant low-income population. But we looked at the counties that, per capita were helped, and they are exclusively in kind of in the center of the state. Really high numbers of people in a lot of counties outside of Philadelphia are being helped by Medicaid expansion. And I want to say it was 250,000. This is the hard part about having everything up on my screen, is that I can't get into my stats. But yes, that is a great question. We do have those numbers. I'm happy to provide them to you if you want to email me. And a sizable majority of the people who are helped by Medicaid expansion are outside of the Philadelphia and Pittsburgh areas.
Great. So, Kristen, at the time, right now, I don't see any other questions. Again, we'll allow for plenty of questions at the end. So if you do have them, feel free to ask them. If we have some breaks in between, we'll allow for them. But if not, we plan on allowing for about a half an hour of questions at the end of today's presentations.
Okay.
Kristen, let's turn it back to you.
Okay, great. So let's talk about Medicaid block grants. So this is the hot topic right now. Instead, what we're going to talk a little bit about is the plan and how they've worked, what the proposals that have been floating around look like, and how they might work. So Medicaid block grants are the hot topic at the moment, and the idea with block grants is that the federal government, rather than reimbursing on this quarterly basis for the expenses, where states report out how many people they enrolled, how much it cost, and then they get their 52% if you're Pennsylvania, or your 95% if you're talking about Medicaid expansion folks, they get those checks cut to them as reimbursement. What happens instead is that the federal government says to states, okay, we plugged your circumstances, whether it's your size or your historic spending or other population factors, into this formula. This is how much you get. And we'll cut you a check on some basis, regular basis, quarterly or whatever. We don't have policies. I am sort of riffing on this a little bit, but we will cut you a check, and that is how much you have to spend on Medicaid. And you spend your money, whether it's the $13 billion that we got in 2015 or $10 billion or some amount of money. That is how much you get. And if you enroll more people, or you decide that you want to cover other benefits, or you have your costs go up unnecessarily, you still have this $10 million to play with, so figure it out. And this is really, there's a lot of talking points about how great this is for states, but ultimately this is a plan that is designed to give states less money than they're currently getting and that they're projected to get in the future, to save a whole bunch of federal money. And it's actually, the CBO has scored past plans at $1 trillion over 10 years. So an enormous amount of federal money over 10 years would be saved by this plan, because you're giving states way less money than they would otherwise get under the current spending regime. And so the way that this works is most proposals start out, and you can see this is from our national partner, the Center on Budget and Policy Priorities. Most states start out and they get maybe a little bit less than they get currently, and the federal government says, okay, well, we're going to give you a bunch of flexibility. So all those rules that I was talking about at the beginning, all these requirements about certain mandatory services or choice of family planning provider, just all these things, we're going to make a bunch of rules. And again, I don't have a proposal, so I don't know what rules those are. I'm just sort of speculating, and this is speculation that's happening. We're going to make a bunch of requirements way less stringent, so you can kind of run your program any way you want. And in exchange, we're going to give you less money to start. So the first year or so is a funding cut, but it is not a funding cut. It's not an extreme funding cut. But what happens is most block grant proposals then historically there have not been any increases to block grants and programs that we have block granted, and I'll talk about that in a minute. But most of the Medicaid block grant proposals that are floating around then increase funding to state based on some sort of inflationary measure that is not Medicaid or health insurance inflation. So, the cost of milk or the cost of a tank of gas, the consumer price index, these inflationary measures that exist measure general inflation, which is around 3%. Medicaid inflation is usually about 7%, which means the cost of running a Medicaid program increase about 7% each year. With Medicaid block grant proposals that are floating around, the idea is, in the first year, as I said, you don't give states a whole lot less money, but then you tie any future increases to this formula to the consumer price index or to another inflationary measure that measures general inflation, which is usually about 3% each year. And so what you are doing after that first year is you are having escalating medical costs and the block grant is in no way catching up or maintaining, keeping pace with medical inflation. And so what that means in practical terms, and you can see this chart, is that over time, states face enormous budget shortfalls. This just rips huge holes in state budgets because states were getting, maybe Pennsylvania, we're getting $13 billion. Then we get maybe a little less the first year, but then as our costs increase, we have to pay more and more money because the federal share is not keeping pace with the cost of Medicaid inflation. And so, in general, what this means is that, and again, these are what we are expecting in old proposals. A lot of things are quite vague right now, and we will have another call once we see a firm proposal. But in general, under block grants, Medicaid would no longer be an entitlement, and many federal Medicaid requirements would likely be eliminated. We have not seen any specificity about what would be eliminated, but this is the promise that people who are supporters of block grants make, is that, okay, states, we're going to give you less money in this first year, and maybe in future years, and you don't have to worry about inflation because you can run your programs in innovative ways. And I think this is, and most people who have really looked at this tend to agree that this isn't really, this is a little bit of a devil's bargain, because what you are signing on to, the kind of flexibility you have, is to cover fewer people and provide fewer services. Because if you go back to this chart, when you're talking about, if you go back to this chart, you can see, as these huge budget shortfalls start to compound and start to grow, you don't have the money in the program to provide care in really cool and innovative ways. You're just trying to keep pace and not go bankrupt as the state. And so you're really looking at cutting lots and lots and lots of services, or really eliminating who can get benefits, or looking at waiting lists or other controls, including bureaucratic red tape, other requirements that are going to keep people out of the program, so that you can, so that the state costs don't explode as the dollar value of the federal share, the buying power of the federal share doesn't increase quickly enough. And so, that sounds really dire, and it feels really dire. There are also other really bad things about block grants. I think the big thing that we have seen with the TANF program, which I'm going to talk in just a moment, is that block grants allow states to divert money away from providing care to pet projects. You know, it kind of becomes a little bit of a slush fund, and that sounds pejorative, and I think it could be pejorative, but in some cases it's just really hard. You have this money and maybe you have expenses that are tangentially related to health. We have found with other block grant programs that it's really hard for Congress or federal agencies to have impeccable oversight and make sure that that money is getting spent correctly. And so in fact, a lot of the money is diverted away from the people and the reasons it's needed most and can be used to fill other budget shortfalls, which actually makes these further decimates these programs. Another component of this is that block grants are really hard to administer fairly across nationally. It's hard to do this in a way where there aren't winners and losers. And the reason it's hard to do this is because, as we talked about at the beginning of this presentation, states aren't funded equivalently. Some states have expanded Medicaid, like Pennsylvania. You have 31 states who are getting a big chunk of federal money to cover Medicaid expansion folks. You have states that spend a lot of money to cover individuals with disabilities. You have states who are and cover lots of benefits and have a much more generous program. You have states who have very bare bones programs and cover the bare minimum and spend very few state and federal dollars on their existing Medicaid programs. And you have states who get, a 75% federal match, and you have states who get a 50% federal match. And so when you figure out how to create these block grants, it's really hard to do this in a way that is fair to states. And the states that tend to be more generous and tend to be getting more federal dollars and now tend to be, states like Pennsylvania and New York, Connecticut, states where the supporters of block grants are not living. And so how do you do this? How do you do this in a way that is politically approachable and that is fair to states without taking a ton of money away from states that are spending more money, or punishing states that are spending less money? It's very, very tricky to do this. And in past experiences, this has really been one of the things that has torpedoed Medicaid block grants. And we are already seeing these conversations from the Republican Governors Association saying, like, how are you going to do this? How are you, like, a bunch of our states didn't expand Medicaid. We thought we were doing the right thing to save the budget, and now you're going to punish us by giving us less money if we shift to a block grant. This is really hard stuff. It's hard to do. I don't know that anybody knows how to do it correctly, if there is a correct way. And then I think one of the final issues with block grants is that they fail to respond to economic downturns. And what I mean by that is that, in the Medicaid program, we really saw a couple things. We saw that there was a stimulus bill that increased the federal match, So Pennsylvania and other states got more money from the federal government to kind of prop up the state budget. That happened in 2009. But even beyond that, we also saw, the nice thing about having an entitlement and having the existing reimbursement scheme is that the Medicaid program grew by several percentage points during the recent recession. And states didn't have to bear all of that cost. The federal government came through not just with its 52%, but with an enhanced match with extra money to help them absorb the shock of so many people needing these benefits. And because it was an entitlement program, everybody who needed these benefits could get them when they needed them. They didn't have to wait and say, oh, well, we've reached our maximum number of people. You'll have to go on a waiting list until we can help you. And so that is a way in which these programs really are safety net benefits. That Medicaid and SNAP, the food stamp program, those are both programs that exist, that really got called on and we really needed in Pennsylvania and across the country in the last few years. And the Medicaid program and the SNAP program, the way the funding works is responsive to that. And it propped up the state economy by making sure that the state could provide coverage without, while it was grappling with huge revenue shortfalls elsewhere, it wasn't also absorbing these enormous costs of care. And so we have seen proposals, many of the proposals have, tie increases in block grants maybe to the unemployment rate or some other economic triggers. The problem with that is that it's not clear. Those proposals are very vague, and it's not clear that those really work, because those of us who work with lower income people, who are lower income people, know that the first people to be hit by a recession or an economic downturn are people who are kind of at the bottom of the earning scale, and the last people to be helped are the people at the bottom of the earning scale. And so when you're looking at like these big picture economic indicators, they don't often capture what people who are receiving Medicaid or receiving other safety net benefits really need. And so there's some real fear that, given the volatility in the economy and some of the uncertainty about where the global economy is going to be going in the next few years, that shifting to a block grant is really going to hurt people and hurt states at a time when people are most in need. I've mentioned this a few times, but I think just to underscore, we have seen these concerns are not purely academic. We have seen that block grants don't work in a very tangible level, state level, and that is through the TANF Cash Assistance Program. In 1996, Congress converted the Aid to Families of Dependent Children with the Aid to Families of Dependent Children Cash Assistance Program, which was an entitlement program run very much like Medicaid. They converted that to a block grant, the Temporary Assistance for Needy Families block grant, to states. And since converting it to a block grant, TANF block grants have not increased not just in terms of inflation, but in real dollars. States are getting the exact same amount of money in 2016 and 2017 that they got in 1996. So as you can really see how the federal government has sort of locked in its long-term savings by just not giving states adequate money to continue to run their programs. And in Pennsylvania, we've seen a number of the kind of parade of horribles that I just outlined happening. Less than 25% of the TANF block grant actually is spent on cash assistance. The vast majority of the TANF block grant is going to support child care subsidies, which, to be clear, supporting, helping people afford childcare so they can go to work is a great goal. But that is not, temporary assistance for needy families. TANF is really intended to help the lowest income families who are in the most dire of circumstances. And that is not 100% not where our TANF dollars go in Pennsylvania. They are really helping higher income working families. And TANF cash assistance grants have not increased since 1990. They have never been generous, but the average TANF family is a household of 3, and they have to live on $400 a month, with the exception of maybe a little bit of child support, with no additional income. And so this is really, really, bare bones TANF grants. And people really, really struggle. It's really hard to pay rent on $400 a month for yourself and 2 children. And we have seen, as a result, there's been lots of bureaucracy, lots of red tape that has been imposed without any sort of federal oversight. And as a result, we've seen that TANF enrollment has dropped really dramatically. We just hit a new low. We had almost 500,000 people on TANF in 1996. It's never been a huge program the way that Medicaid, for example, is. But it's still, we had 500,000 people on the program. We hit a all-time low in December. We've dropped below 150,000 people for the first time. That is not something that we are celebrating, and it really illustrates the ways in which converting TANF to a block grant has really just decimated Pennsylvania's safety net. And we saw that in the recession. We saw, huge increases in Medicaid and SNAP, and not anything remotely like a corollary increase for families who were left without income because of the recession, accessing TANF benefits. This is really, I think, a story some people have focused on, but not enough people have focused on. It's just this baseline subsistence benefit is just not helping the people who need it most. I want to pause in just a moment to take questions, but I do want to say a few words about per capita caps. This is most of the conversation around Medicaid spending or funding reforms has focused on block grants. But there's another proposal floating around focused on per capita caps, which are sort of in many respects a block grant by another name. And I want to just stress that. Because I think what we are hearing from folks is who hear about block grants and think, oh my goodness, that is so horrible. And they hear about per capita caps and they think, oh, all right, well, I could live with that. Per capita caps are just as bad. They're just repackaging a lot of the terrible things about block grants into a new and maybe trendy, I guess, structure. And so what per capita caps are is instead of getting one big chunk of money, one big lump sum, the state tells each person, the federal government tells the state how much they think it costs for them to cover a person enrolled in Medicaid. And so, I said earlier that we spend about $1,000 for a kid. We spend about, $13,000 to cover an individual with disabilities. They may say, okay, we're going to give you an average of $4,500 to cover each person that you enroll, and just figure out how to cover them. And that may help. That may be more than we're paying for for a lot of people, but it's not enough. It is not an equivalent amount of money that we are paying overall, especially for people with the higher needs. And those per capita caps, again, would be tied to some sort of consumer price index or some sort of inflationary metric that is not medical inflation. And so if medical inflation drives costs up, the per capita caps don't go up accordingly. I think the other piece to keep in mind about this is that it's not just inflation that we're talking about when we talk about costs going up. For example, we saw huge strides made in the world of hepatitis C treatment, and many of those therapies are quite expensive and also required, and to keep people healthy. And so the federal government has paid a significant share of the cost to states of providing treatment for hepatitis C to folks. With a per capita cap, those payments from the federal government would not necessarily adjust to reflect changes in therapies or new costs of care. It's a fixed amount of money, and states would have to figure out, either bear the costs of, these innovative drugs or not cover them at all, leaving lower income people out of treatment options altogether. And so with thanks to our partners at the National Health Law Program, I think there may be somebody on the call, so thank you for this excellent graphic. You can see, this is a method to save federal funding. Again, same amount of money, scored at the same amount. So this is not by any means a more generous approach. Saves exactly the same amount of money. You're just tying payments to states for per person enrollment instead of one big lump sum. And again, you see states would face huge budget shortfalls, forcing them to cut benefits or limit enrollment. Enacted through federal budget reconciliation. We've been hearing a lot about that, I know, in the press and elsewhere. Reconciliation is the process through which legislation that affects the federal budget can pass with simple majorities in both houses of Congress. And what that means in practical terms is that it is not, budget reconciliation bills can't be filibustered. You only need a simple in the Senate to pass budget reconciliation bills. We know, unfortunately, that block grants can be passed through reconciliation because that is how TANF block grants were enacted in 1996. So there is clear precedent for using budget reconciliation bills to convert entitlement programs to block grant programs. Very sad to say. What we had heard in December and January is that Congress was going to pass 2 reconciliation bills. They can only do one a year. they didn't do a 2017 bill. So they were going to do a 2017 bill in January 2017 to repeal the ACA, and then they were going to do a 2018 bill sometime later in the spring, around April, to move forward with tax and or entitlement reform. So there's some talk about not just doing Medicaid block grants, but doing a human services block grant, which would adjust, which would maybe change SNAP, the food stamp program, and a number of other programs into one mega block grant. A lot of things are out there in the world that were floated to happen in the April 2017 reconciliation bill. It's not really clear now because we know that ACA repeal has been delayed. Now we have heard Congressman Ryan say, Speaker Ryan say that maybe they're going to try to do something in late February, early March. It's not clear what's going to happen to with Medicaid funding and when that will unfold. But I think it is. I think what advocates are really worried about is that as this issue around the ACA repeal becomes thornier and thornier, Congress is going to say, okay, well, we're going to fix health care by, playing around with Medicaid and fixing Medicaid, and that actually this isn't going to be a sequential issue where the ACA is going to be repealed and then we focus on Medicaid, that, people are going to really try to affect the health system as more and more as they feel like it is complicated or tricky to affect the ACA or repeal the ACA. They're going to do Medicaid and focus on Medicaid instead or simultaneously. And so I think, I want to be really clear that this is something that we think is happening soon. And it's really, really important that people be educated and knowledgeable and on alert to really speak out and protect the Medicaid program, because I don't think that just because the ACA piece has been moving slowly, that means that that any threats to Medicaid the can has been kicked down the road, that those threats exist and they exist now, and we need to be organized and ready for them. And in fact, I think we've heard both President Trump and Senator Toomey in the last week, when they were asked about ACA reform and what they plan to do, pivot and say, well, I really want to block grant Medicaid. And so we really fear that this is going to become an instead of an in addition to ACA repeal. And so we all have to be ready and vigilant and prepared. Just before we talk about what you all can do, and I can turn it back to Patrick for questions and for opportunities to get involved, I just want to highlight that the threats to Medicaid are not exclusively legislative, unfortunately. As I had said earlier in this presentation, CMS, the Centers for Medicare and Medicaid Services, have been really vigilant under the Obama administration and before in making sure that they did not approve state waivers to make medical assistance or Medicaid harder to get. They were really clear with states that things like lockout provisions for people who can't pay very high unaffordable premiums, or work requirements even for people who are unable to work or unable to find work, that those requirements had nothing to do with the requirement of the Medicaid Act that the program be administered to furnish medical assistance. And we saw, for those of us who were paying attention during Healthy Pennsylvania, the request to really change how Pennsylvania expanded Medicaid and operated its traditional Medicaid program. We saw CMS tell the governor at the time, no, you can't do this. This doesn't have anything to do with furnishing medical assistance, and in more and less legalese term, this has nothing to do with keeping your residents healthy. We're not paying for this. We're not letting you use federal Medicaid dollars to make your program more difficult to access. And unfortunately, the Trump administration has nominated as the head of CMS a consultant behind a lot of these types of proposals, who really has led the charge in states asking for things like work requirements, lockout provisions, other things that were really unpopular in Pennsylvania and were ultimately rejected by CMS. And so we are expecting that in the next few years, lots of states will use Medicaid dollars to erect these kinds of barriers to their programs. And so I just want to acknowledge that we have a gubernatorial election in 2018, and that it will really matter what kind of positions candidates for governor, the existing governors take on these kinds of reforms, because I think a lot of us worked to really send a message that they weren't right for Pennsylvania, and ultimately those kinds of reforms were rejected. But we may see them again, and we just again need to be vigilant and prepared, and recognize that it's important at not just at the federal level, but at the state level, to have champions of a strong strong and accessible Medicaid program. So with that said, I mean, that's a little bit down the road. We are facing an immediate fight around protecting Medicaid at the federal level. And so there are a few things that you can do today. One is to join the Ensure PA campaign, and Patrick will talk about that at some length in just a moment. I want to just direct you to our website, clsphila.org. I'm assuming that Patrick will be sending out our PowerPoint. We will also make sure that we post it online at our website. We have a number of fact sheets on block grants. We have a general one about how block grants work and why they're bad. We have a block grant a fact sheet that talks about how block grants, how Pennsylvania doesn't need additional flexibility, how we have enough flexibility already, and that block grants don't give us additional flexibility. We have a number of fact sheets about how Medicaid works and why Medicaid expansion has been a success in Pennsylvania. We also have information that you can use to contact your U.S. senators in Pennsylvania. Senator Pat Toomey, who is, as I said earlier, a supporter of Medicaid block grants. Senator Bob Casey Jr., who has been a supporter of a more traditional, the existing Medicaid funding system. You can contact both of them and make sure that your voice is heard in support of existing Medicaid, the existing Medicaid funding structure. And as I said, on our website, on the homepage, there's a button you can click. It has these phone numbers, and it has talking points, and it also has some quick facts that can help bolster your argument. So please do check that out. And with that said, Patrick, I will pass it off to you to talk a little bit more and take questions.
Great. So Kristen's contact is up here. We're going to allow for a bunch of questions. I want to put in, before we end, a quick plug for Ensure PA. Many of you are already aware of the Ensure PA platform, but in case you haven't already heard, Ensure PA is a group of stakeholders from across the Commonwealth of Pennsylvania that want to fight to protect the Affordable Care Act and make sure that we don't do damage to it by imposing block grant or per capita cap schemes, as well as eliminating coverage or getting rid of other consumer protections from the Affordable Care Act. If you're an organization, we'd like to make a pitch for folks to kind of sign on to the principles of that campaign. More information is available on Ensure, INSUREPA.org. We'll include a link to that in our follow-up to this webinar. We'll be sending out both the slides and the recording to this webinar. So please be aware of that. But really, the 5 points of Ensure PA are that all Pennsylvanians should have access to high-quality, affordable health care. We deserve a plan now. We don't have time to wait, and a delay would be harmful to our economy. We can't go backward. We need to preserve the coverage and the protections that we've gained under the ACA. Medicaid, Medicare, and CHIP must be protected, and our safety net, including our hospitals, health centers, especially in rural or underserved areas, must be protected. So that's what we would be asking your organization to sign on to. We also have a petition online that you can circulate among family and friends. And our goal there is to just demonstrate in as many ways as possible the enormous impact that Pennsylvania has had from the Affordable Care Act. I should also mention that for folks that are looking for, Kristen mentioned reaching out to our state senators and other members of Congress. For those that do want rapid updates on the situation as it's emerging in DC, you can text 412-512-9225. Again, we'll put that out in the follow-up, but the number is 412-512-9225. And we can sign you up to get more immediate alerts about things as they unfold in Washington. So I know that there's a lot of questions. I'm going to start. Kristen, again, you can either raise your hand or ask the question through the question box. And I also apologize. I know somehow many of you lost me, so apologize for the sound glitch there. But please let us know if you have a question either by raising your hand or by typing it into the chat window. So the first question, Kristen, was about jobs. Do we have a sense of how many jobs, if Medicaid was block granted or ACA was repealed in general, how many jobs we would lose?
Sure, that's a great question, and it's tricky because we don't know. When we talk about Medicaid block grants, we don't know for sure what we're really focused on, because we don't know we don't know, would Pennsylvania be a winning state? Would it be a losing state? How would this formula work? And how much money does Pennsylvania really stand to lose? I think that's where we're going to reconvene once we see a firm legislation or firm proposal that really allows us to figure out what we're looking at in Pennsylvania. We are partnered. Pennsylvania Budget and Policy Center had put out a paper 2 weeks ago that focused on the economic impact of ACA repeal more generally. And Patrick, you're going to have to help me. It was 137,000 jobs, I think, was the projection. Is that right?
Great memory. There were 137,000 jobs. You're right, Kristen.
Okay, good. It's tricky. It's so hard to do this out from memory. and so that was their projection, and they have analysis about how we arrive at that number. What we know from Medicaid expansion, scholars have looked at national job statistics in expansion states and non-expansion states. What they saw was that particularly in the health insurance and social service sector, expansion states had 30% more growth in those sectors than non-expansion states did. And so we know that robust funding for Medicaid actually does create jobs. It creates a lot of jobs. And so any changes or any cuts in Medicaid don't just harm the people who are receiving Medicaid, they also harm the Pennsylvania economy and hospitals and healthcare providers and the state government as well, which does which has been able to shift some state costs to the federal government through Medicaid expansion and through that enhanced federal match.
So, Kristen, another question that we've been having in the chat window is about the bottom line message here. Right now, it's important for folks to know that Medicaid is an entitlement program, and shifting this, to a block grant scheme or a per capita cap scheme would remove that entitlement requirement. Can you talk a little bit about the impact of moving Medicaid from entitlement? Just summarize, what that would actually do to folks.
Yeah, I think it's a little hard, as I said. And I apologize. I think we definitely wanted to tell people as much as we knew, but we don't know exactly what kind of flexibility states will have. We know in the TANF program, TANF stopped being an entitlement, and so we very much expect that Medicaid would be the same. I think what we expect to see, I think the entitlement piece is sometimes a little tricky if you are thinking about top-line messages. I think what's really important for people to know is that TANF block grants the only flexibility that TANF block grants create is the flexibility to cut benefits, create waiting lists, or otherwise limit eligibility. And that is because states would have to move to close huge holes in their budget from the loss of federal dollars, and those budget holes would grow over time. And that's, I think, ultimately what we want to be talking about is the huge loss of money to the states, and also that the fact that we're tying states' hands, and that states, Pennsylvania is already dealing with a really dire budget picture right now. We really blowing up the state budget in this way doesn't enable it to do anything except cut benefits.
Kristen, another question that one of our participants, Kelly, has is, could you talk about the reasoning behind going to a block grant that's given by its supporters? Is there a goal to save federal money, and if so, do they expect states to bring in additional revenue to cover the losses? Or is the argument that we're spending too much on healthcare overall? Great question from Kelly.
Yeah, I think this is a great question, and I think there are a few arguments that you have seen floated. I think one of the arguments that we hear we've touched on already, and that has to do with this flexibility argument, this idea that the federal government has tied states' hands and states have not been able to innovate and provide care more effectively. And so, what we talked about at the beginning, I think that's why I spent a lot of time at the beginning of this call running through what's required and what is optional. So you can see, the kinds of requirements that we're really focused on are really baseline benefits, giving benefits to everyone who qualifies, and not discrimination. Like that's really what we're talking about when we're talking about and ensuring access to care at community health centers, family planning providers. These are the kinds of things we talk about when we talk about these state requirements, which I'll wear my hat and say those are pretty good things. Those are things that we would want to see in a health insurance program. And so, but that's the talking point, is that states have had their hands tied for too long. They've been told no on work requirements, they've been told no on all these quote unquote innovations, and we want to give states the freedom and the flexibility to do it, to run those bases best. And again, I mean, the counterpoint is we have a lot of flexibility, and unfortunately when the people who are talking about flexibility are really talking about the flexibility to limit benefits or to make it harder to qualify for benefits. That's the primary talking point. We've seen a couple other talking points emerge, and we saw Senator Toomey talking about this a couple in the last week, saying, Medicaid is a failed program, and people just because you can get access to, just because you have an insurance card doesn't actually mean you can get care. And in fact, there's been a great report that came out from the U.S. Department of Health and Human Services talking about how people who are covered by Medicaid expansion have had great access to care. They've been able to get preventive services. They've been able to get prescription drugs filled. They've been able to access services. And Medicaid is really built to be protective of those folks by, as I said earlier, making sure they have access, requiring states to ensure access to health centers, to federally qualified health centers, requiring states to offer choices of family planning providers. If you have a managed care system, you have to have a competition to make sure that people have choice among networks. You have to have choice of providers in areas. This is not perfect. I'm sure there are people on this call who are like, this lady's crazy. This does not work perfectly for everyone, and it doesn't. But it works really, really well compared to any of the alternatives that have been floated. So I think that's another argument that we hear a lot. And then we also just hear this budget issue, this budget argument that we're just spending too much on Medicaid. And it is true that we're not talking about minimal dollars here, but I think there's a values-based question about where we think it's fair to spend money. And many of the proponents of people who want to eliminate Medicaid want to use that money to fund tax cuts for the wealthy. And so I think there's a really strong values conversation to be had here about where tax dollars are spent best.
Great. So we've got about 3 questions for you before we wrap up. So I'm going to unmute Deborah Reynolds, who has a question for you. Deborah, are you there? Deborah, can you hear us? Okay, so she had asked this question through the chat window as well. So, what is Governor Wolf's stand on block grants versus traditional Medicaid or Medicaid as it's currently structured?
Yeah, I think that's a great question. I don't know, and others, Patrick, you can chime in. I haven't heard him come out specifically in opposition to block grants, but he has been a huge supporter of the existing Medicaid program. He's really celebrated Medicaid expansion and viewed enrollment as a positive thing. He and his administration have taken a lot of steps to eliminate red tape and make the program accessible for people who qualify. We saw in a letter that he and his administration sent to to Congress upon request, asking how Medicaid should be changed, saying, you know, Medicaid's working and we've saved $500 million in state funding by having Medicaid expansion. We've helped 63,000 people get treatment for opioid addiction. This is a program that really works for Pennsylvania, and we want to keep it as it is. And so I haven't heard him speak specifically to block grants being bad, but he said lots and lots of things in support of a robust Medicaid program that looks like the one we currently have.
So we're going to go to another. Thanks, Kristen. We're going to go to another question from Marianne. Marianne, I'm going to unmute you now. Are you there? Can I ask you a question?
Hi. Yes, I'm here. Can you hear me?
We can. Go ahead.
I can hear you.
Hi, thanks. I really have two questions. The first goes back to the very beginning when you talked about block grants as being an amount of money that the states can choose to use. Did I understand that correctly? They can use it on anything they want? Or did I not understand that correctly?
Yeah, so that's a good question. And again, it's a little hard to answer that very precisely because we haven't seen a firm proposal, so I apologize. What we have seen in the TANF program is that states have had a lot of leeway to spend their money on things that are sort of related to TANF cash assistance, but are not actual cash assistance grants. And so in the TANF program, we've seen in Pennsylvania, spends $1 million on supporting crisis pregnancy centers, which are centers that provide, you know, many people say misinformation to try to steer women away from choosing abortion services. We spend lots and lots of on child care. Michigan spends money on middle class college scholarships for middle class families, you know, merit scholarships for much higher income families, regardless of whether they're low income or not. And so this is sort of an endemic thing across the across the country, is that states have had incentive to really shrink their roles through more stringent rules or red tape, and then use the money saved to fill budget holes elsewhere or to support pet projects. And that is, in general, I think that the fear and the anxiety around block grants. Without having seen this proposal, I can't tell you for sure that that's how the Medicaid program will work, but it is definitely a pretty significant risk.
Yeah, that's pretty frightening. The other question, and this may be related to that, is we don't have any idea what the formula will be for deciding what the amount that each state would get.
No, we haven't seen a proposal, and any of the proposals that are floating around don't go through that formula. And I think that ultimately that's a conversation, going to be a national conversation, because you can't do this without having states who are winners and states who are losers. Right. And we don't know, would Pennsylvania be I want to be really clear. Every state will get less money than they currently get, and those losses would be compounded over time. But some states would get markedly less, and some states would maybe get more relative to each other. But this isn't good. You know, none of the 50 states are going to be in great shape from this proposal. But I think one of the conversations that we should be paying attention to and really thinking about as a proposal is introduced, and as we see more about how it would work on the ground, is, would Pennsylvania be a winner? Would we be a loser? And how can we talk about this in a way to really highlight our opposition?
Okay, thanks. I appreciate it.
Thanks, Marianne. And just to be really clear, we, are hearing from national partners in this campaign that, really by going after Medicaid and our healthcare safety net, this is, a clear way in which, if you're going to do that second reconciliation package that Kristen talked about, you need to be able to save money somewhere to provide, tax cuts. And so, this is clearly something that's very troubling to all of us. So the last question that we have is from Sharnique, and she's asking, is block grant something that will affect only Medicaid expansion and the ACA, or does it apply to traditional categories of Medicaid as well?
Yeah, that's a great question. What we are hearing is that a block grant would be for the entirety of the Medicaid program. And so just to be really clear, what we're talking about is rationing care. So we're talking about, well, that's partly why I spent a lot of time at the beginning talking about who is covered and how we cover them and how much it costs. Because what we're really looking at is, as states get less and less money, we don't really anticipate that the state then jumps in to kick in an additional billions of dollars, because Pennsylvania doesn't have extra billions of dollars. We have a huge budget gap as it is. So we are really looking at then a state fight about, do we cut benefits to children? Do we cut benefits to individuals with disabilities? Do we throw categories of children or categories of adults off the rolls? Do we, provide less coverage or a less robust benefit to seniors in nursing homes? Like, these are really the conversations that we have if Medicaid goes to a block grant. And so, we've talked about, I think there's been a lot of fear about quote unquote rationing of care. This is really what it looks like. This is, in practical terms, the conversations that we will have to have if block grants are enacted is, do we want to cover pregnant women? Do we want to cover kids? Do we want to cover people who need home and community-based services? How do we spend a shrinking pool of dollars on lots of people with very high medical needs, and who is the more worthy and who is the less worthy? And that, to me, feels abhorrent that we're going to have these that we would have to have these arguments at a time when there was so much angst about, care rationing when the ACA was being enacted. And so I just want people to really understand that that's what's at stake here, is requiring states to make those kinds of value judgments about who is not the most worthy for an adequate amount of medical care.
So, Kristen, that's actually a great place to kind of end today's discussion with a follow-up call to action. So I think that we've had over 200 folks express interest in this webinar, more than 200, and I think all of them are really concerned about our healthcare safety net and would agree with you that it would be abhorrent to have to make those really tough decisions about rationing healthcare. So I know I cut out a little earlier, so just to recap, we've got Insure PA as a campaign to fight to keep all of the gains that we've made in coverage, all of the consumer protections that we've had, and keep Medicaid, Medicare, and CHIP programs that work intact. And so I'd really invite all of you, if you're interested in taking those next steps and fighting for the ACA here in Pennsylvania, we need as many individuals and organizations committed to doing so. And so I'd invite you to go to insurepa.org, insurepa.org, and either sign the petition, or if you're interested in actually joining the campaign, you can reach out to us after with the follow-up email that's going to be coming out and let us know that you'd like to sign your organization on. As Kristen mentioned, we don't have legislative language yet, but we are expecting to see proposals come out, and we will certainly need to quickly mobilize folks. We would ask, if you're interested in getting text updates when your action is most needed, you can text JOIN, JOIN, to 412-512-9225. Again, that number is 412-512-9225, and we'll include that in the follow-up to this webinar. Many of you asked about slides and a recording. We will be sending out those to everyone that's registered for this. We would invite you to share that. We really need to spread the word about the harmful impact of block grants and per capita caps. As Kristen mentioned, in the next couple of weeks, we'll be hosting another webinar to go into more detail about some of these replacement plans and what they would actually look like for Pennsylvania. So please stay tuned for that. And we want to certainly thank Kristen from Community Legal Services, always a great partner on topics related to Medicaid, and we really appreciate their support in breaking down these really complicated issues for all of us that aren't lawyers, but yet really want to fight to protect our Medicaid and our health safety net. So thanks a lot, Kristen.
Yeah, thank you all so much for having me. And please don't hesitate to reach out if I can get you information, especially folks who I promised stats that I didn't have, that I couldn't access on this call. Please feel free to shoot me an email and I'll send you what I have.
So Kristen's email is up there, and again, you'll be getting a follow-up email. So if there's anything else you need from us, please be in touch. Thank you, everyone, and have a good day.